Hello and welcome back to Score USMLE. This is the third and the final video in the Spinal Pathway series. We'll be studying here the diseases that affect the spinal cord and practice some of the USMLE style questions. Now let's begin by revising for a moment what we learned in the second video. So take a moment, pause the slide and revise what we have learned in the second video. So let's move on and begin with the diseases of the spinal cord. So to begin with, let's start the Brown-Sequard syndrome. Now, Brown-Sequard syndrome is another name for the hemisection of the spinal cord. Now, hemisection means transection of one half of the spinal cord. So this shaded area here in my example can be called a hemisection. So let's move on and let's see how this applies clinically. Now guys, even before I tell you this concept, I want to impress upon your mind how important it is to understand this clinical application. Whatever you learned in the second video, however well you may know the theory of the tracts, if you do not know how to apply it, like I'm going to teach you here, if you do not know that, there's no point, there's no use of knowing all the theory, because USMLE is going to ask you questions on this application, and as a doctor you will be required to be able to use this information instead of just knowing it. So now we'll be studying this hemisection in three parts. The first part would be the effect of this transection on the segments that are below the level of injury, meaning to say T11 and below. And the second part would be the effect of this transection on the level of the spinal segment injury. And the third part would be the effect of this transection on the segments that are above the level of injury. So now let's begin with the effect of this transection on the levels of spinal segments below the level of injury. So what we're going to do is keep tabs about the sensations or the motor neuron that will get affected on the both sides of the spinal cord. Now remember guys, the left T10 segment got injured here in this poor patient, and the right side was fine. So let's begin with the right side, as we always begin with the normal side. So let's begin with the vibration, proprioception, and discriminative touch pathways. So what happens on the right side in the segments below the level of injury is that the first order neuron brings the sensation to the dorsal column and ascends in the dorsal right column. Is that a problem? Nope. All the dorsal columns of the spinal segments below the level of injury are easily able to ascend without any problem. So the vibration, proprioception, and the discriminative touch modalities will remain normal on the right side. We put a tick mark there. But what about these sensations that are carried by the dorsal column on the left side of the body below the level of injury? So the first order neuron would bring the pieces of information to the dorsal columns at their specific spinal levels, and that would ascend through the spinal cord to emerge through this area of the T10 damaged spinal segment. With this information on the ipsilateral side of the injury, that is on the left side of the body, would this information be able to ascend through the spinal cord? No, because the dorsal column, the axons traversing through the T10, these axons of the lower segments traversing through this T10 segment are now damaged. So this sensation, these sensations rather, on the left side of the body are not transmitted to the brain. But let me remind you guys, all of this analysis about these sensations carried by the dorsal column has been done about the level of spinal cord below the level of injury. We are not yet arrived at the level of injury and above the level of injury. So we'll talk about that later on. But continuing our journey of the analysis below the level of injury. So coming on to the pain and temperature sensation, let's begin again on the right side. So if you remember from the previous video, the pain and temperature sensation is brought by the first order neuron to the dorsal gray column, where the second order neuron takes over and is supposed to ascend in the lateral spinal thalamic tracts. And that's how it happens for all the inferior segments. But again, we've discussed the scenario in the second video as well. So these tracts ascending through the lateral spinal thalamic tract of this transected T10 segment, will they be able to transmit that piece of information to the brain? What do you think? On the right side, and we're talking about the right side, would this information from the right side of the body below the level of injury be able to ascend to the brain? No. But what do you think is the story of the left side of the body below the level of injury? That is the ipsilateral side of the body below the level of the injury. So again, the first order neuron was supposed to present the information to the dorsal gray horn, where the second order neuron was supposed to pick this information, cross over to the opposite side, and ascend in the lateral spinal thalamic tract. And this was supposed to happen for all the inferior segments. That's right. Now, will these tracts be able to traverse through the T10 spinal segment on the right side? What do you think? Yes, because the right side of the spinal cord is not injured. Do you realize that the left side of the body below the level of injury will be able to sense these pain and temperature sensations because the right hand side of the spinal cord of the T10 segment is fine? So yes. So now let's come on to the pressure and the light touch sensations. Now, to make your life easier, I would tell you that the pressure and the light touch sensations follow the exact same pattern as the pain and temperature sensations do. Now, why is it so? Because if you remember, guys, the pressure and light touch was being carried by the anterior spinal thalamic tracts, and even these sensation pathways used to cross over at the level of the spinal cord, just like the lateral spinal thalamic tracts that we just read. So it will follow the exact same pattern. Try figuring that out yourself. It's exactly the same. It's nothing difficult. So now let's analyze what happens to the descending tracts below the level of the lesion. So if you remember, the lower motor neuron begins in the anterior gray column, while the upper motor neuron is the one that is descending through the lateral corticospinal tracts. Now, for the levels below the level of injury, you can see there is no problem in the anterior gray column of these segments below the level of injury. There's no problem with that. So the lower motor neuron is fine for these segments. But what about the upper motor neuron? Now, the segments of the right hand side below the level of injury are easily receiving those corticospinal tracts. They continue to descend without any issue. So the upper motor neuron and the lower motor neuron are both fine on the right side. But what about on the left side? We did establish that the lower motor neuron is not at any risk in the lower segments on the left side as well. But what about the upper motor neuron? That was descending through this tract. Am I right? Yes. So the corticospinal tract got interrupted here at the level of T10 on the ipsilateral side, and that's why these segments of spinal cord below the level of injury will face some issue that will present like an upper motor neuron lesion. So to summarize all of these findings on this patient, I would say let's first identify the level of the lesion, that is T10, the umbilical level, and we will be summarizing all the effects below the level of lesion. So this patient has lost pain and temperature sensations on the contralateral side of the injury. Remember, the injury to the spinal cord was on the left side, so he has lost the pain and temperature sensations on the right side. Also, he has lost the light touch and pressure sensations on the right side. But what about the vibration, proprioception, and discriminative touch? That is fine on the right side, but has been lost on the left side. And what about the motor symptoms? So his contralateral side, that is the right side, faces no issues with the motor symptoms, while the left side below the level of lesion, that is the ipsilateral side, faces upper motor neuron type symptoms below the level of lesion. Alright, so that completes everything that we needed to know about the effects of such an injury below the level of injury. Now, I know that got difficult, guys, and I'm with you, but being a doctor never gets easy, so keep your spirits high and take a moment here, I would say, and just absorb everything that we've learned so far. And there's barely anything left to tell you about the effect at the level of injury and above it. So let's move on here. Alright, so just follow my lead here. So if you see, there's always a dorsal sensory neuron that relays the sensory information. All the sensations, by the way, enter the spinal cord through this dorsal root of the spinal nerve. Now, at the level of injury, all of this spinal cord here is injured. So what do you expect would happen to all the sensations that flow in to the left side of the spinal cord at the level of T10? You're right, all those sensations will be lost because the dorsal root of the spinal nerve entering in the dorsal gray horn is destroyed here. And hence, on the ipsilateral side of the injury at the level of the spinal segment, all the sensation is lost. There is no sensation in this dermatome here. While the contralateral side of the injury continues to be fine. As you see, all the sensations would flow in on this side and would continue to be relayed. So this side is fine. And what about the motor pathways? So guys, when this part of the spinal cord got transected, it also took away the anterior gray horn, which contained the cell bodies of the lower motor neuron that used to supply the effector muscles. Now, this side, the ipsilateral side of the injury of the dermatome at the level of the injury, will face lower motor neuron type symptoms. Alright, and very briefly, everything above the level of injury is always fine. So both the sides, all the motor and the sensory pathways are fine above the level of injury. So moving on, this diagram summarizes the Brown-Sequard syndrome, and while you can take a look at it, let's revise. The lower motor neuron lesion symptoms, which are flaccid paralysis, areflexia or hyperreflexia, fasciculations, weakness, decreased tone, and atrophy, while the upper motor neuron lesion symptoms are spastic paralysis, hyperreflexia, increased tone, and Babinski positive. And Babinski response is the upward flexion or the dorsiflexion along with the fanning of the other toes, like it's shown here in the diagram. Alright, so let's move on and cover some of the other spinal cord diseases. Now, poliomyelitis and spinal muscular atrophy are two such diseases which involve the anterior gray horns, where these are destroyed. And if you remember, here was where the cell body of the lower motor neuron rested and the axon of which used to supply the effector muscle. Now, when these neurons are destroyed here, this gives the patient lower motor neuron symptoms such as paralysis, flaccid paralysis, areflexia, or fasciculations and atrophy. Moving on to multiple sclerosis. Now, multiple sclerosis is a disease which causes many lesions in the central nervous system, lesions which cause demyelination of the white matter. Now, it mostly causes asymmetrical lesions in the central nervous system and is often distributed over space and time. Meaning to say that multiple sclerosis causes different demyelinating lesions in different locations of the central nervous system, and this happens over time, every time there's a flare-up. So, and other features of other symptoms of multiple sclerosis include intention tremors, scanning speech, internuclear ophthalmoplegia, etc., which will be discussed in the detailed neuroanatomy lecture. And here's a disease known as amyotrophic lateral sclerosis. Now, this is a disease which involves both the upper motor neuron pathways and the lower motor neuron pathways, meaning to say the corticospinal tracts and the anterior gray horns, and hence it will have both the upper motor neuron lesions and the lower motor neuron lesions. Now, what is so special about this disease is that it has no sensory, cognitive, or oculomotor defect. Now, you need to remember this, and an easy way to remember it is with an example of one of the famous physicists of our time, Stephen Hawking. Now, he has no cognitive defect. We all know that, right? So that's how you can remember that. So moving on to tabes dorsalis. Alright, so tabes dorsalis is a disease that is caused by tertiary syphilis. Syphilis is caused by Treponema pallidum, as you might remember, and it involves the dorsal columns and the sensory roots, as you can see right here. So dorsal columns carry the discriminative touch, vibration, and proprioception, and the sensory roots bring in virtually every sensation to the spinal cord. So basically, the symptoms will be impaired sensation and proprioception. And if you remember, in the second video, I explained in detail how proprioception is the conscious input from the muscles and the joints of the body to the brain. And because proprioception is lost in tabes dorsalis, there's poor coordination, and that leads to a rhombic sign being positive. You know, rhombic sign is a clinical test where you ask the patient to close his eyes and stand with his feet joined together, and that causes the patient to lose his balance because there's no visual input to his brain showing him how to maintain the balance, because his eyes are now closed and his proprioception is damaged. That's precisely why he will lose balance, and that's why the rhombic sign is positive. Now, also, the deep tendon reflexes are absent. As you can see, for a deep tendon reflex, the first prerequisite is that the tendon stretch reflex should reach the spinal cord, which will not reach in this disease because there is involvement of dorsal sensory roots of the spinal nerve, and hence the DTRs are absent. Also, some other features of tabes dorsalis are Archer-Robertson pupil and Charcot's joints. Alright, so moving on to the anterior spinal artery occlusion. Now, guys, this is a topic of the blood supply of the central nervous system, but it does deserve a mention here because this anterior spinal artery supplies the anterior 2/3 of the spinal cord section. Now, when the anterior spinal artery is blocked, this entire anterior 2/3 of the spinal cord undergoes vascular injury, and hence the only columns working fine in such a patient would be the dorsal columns, which would carry, again, as you know, the discriminative touch, vibration, and proprioception. Alright, so let's move on to our next slide. And this is a really important disease, guys. You need to know this. It's kind of their favorite, and they do ask many questions on it. So this one is known as Siringo Millia. Now, what is so special about this disease? Now, in this disease, what happens actually is that the central canal, which is supposed to be its usual standard narrow central canal, does not remain so narrow. It starts to expand. This is a cavitary expansion. Now, so there's a cavitary expansion of the central canal, and the most commonly involved segments of the spinal cord are the cervical segments. And there's a loss of pain and temperature sensation. Now, how is there a loss of pain and temperature sensation? Now, guys, do you see what this is? Do you remember in the very introductory video of the spinal pathways, I mentioned that this was anterior white commissure. Now, this is where the second order neurons of the spinal thalamic tracts, the lateral spinal thalamic tracts, cross over to the opposite side and ascend in the lateral spinal thalamic tract. This is where these second order neurons cross over, and this expanding cavity presses on these pain and temperature second order neurons, and hence causes this sensation to be lost, and that's why there is loss of pain and temperature sensation. Now, also, since the most common segments involved are the cervical segments, which of course is the area of the brachial plexus, that causes the very typical distribution of this pain and temperature sensation loss, which is known as the cape distribution. Basically, in the cape distribution, there's loss of these sensations on the back of the shoulders and also the upper limbs, and that's why cape distribution. Now, Siringo Millia is also associated with KRE1 malformation. Now, KRE1 malformation is a topic of discussion for another video. Now, guys, I know I promised you some USMLE style practice questions towards the end of this video, and I'm really sorry, but we're running a little short on time for this video. So what I'm going to do is share some practice questions in the description of this video below. Now, for those of you who attended all the 3 lectures in sequence, I really hope that you're able to answer these questions. Please put your answers in the comment section and we'll discuss them there. Thank you so much for watching the Spinal Pathways with Score USMLE. I really hope that you benefited from our videos. For more lectures and videos, please visit www.scoreusmle.org.